For the multi-filament, that's kind of like a rope. Like when you think of a rope, there are all those different, strings that are coming together that are forming that rope. So that's kind of more like a multi-filament, whereas a monofilament is just one single little band that goes through. And for most things, you'll want to use a multi-filament, but reasons to use a monofilament are to reduce bacteria. If you have multi-filament, and there are little areas and cracks for bacteria to get in and more likely lead to an infection, whereas if you use a monofilament, there's just less surface area for the bacteria to grab onto. And finally, with the sizing, most of the time you'll hear 3.0, 2.0, 1.0. I don't really hear the 1, 2, 3 too much, but it's kind of like gauges to a needle or to shotgun shells if you're into that kind of thing. But so 3.0 is going to be smaller than 2.0, which is going to be smaller than 1.0. So 1.0 is going to be larger than 2.0, if that makes any sense. Next slide. And here are just some surgical instruments that you'll see most often. Most frequently, you'll use the tissue forceps, and those actually have little teeth on them. And so when you grab the skin, it'll bite the skin so you can get really good traction. I don't really see dressing forceps too much. Hemostats you can use occasionally to drive a needle, but most often you'll use a needle holder or needle driver, and they're just kind of tweezer-like things that will grip onto the needle, and you can drive that needle through. And then the scissors you see here are just meant to cut suture, and it would be nice if people actually use the proper scissors to cut suture, but really when you go into the clinic, they'll pretty much just cut it with whatever they have at their disposal, which is no big deal because it cuts out pretty easily. And then scalpel blades. So there are lots of different scalpel blades. The three you see up here are by far and away the most common. The blade label A is a number 11 blade. Number 11 blades are most often going to be used for draining things or performing a shave biopsy. They've got a really fine point, and so they're kind of for really small incisions to make. The one that's labeled B is a number 15 blade. The 15 blade can kind of be considered like a mini number 10 blade, which is the one labeled C. But for B, it's for smaller incisions, less than 5 centimeters. And typically when you're cutting on someone's face, you don't really want to gash up someone's face if you can help it. So you'll use a smaller blade. And actually, if you look closely with B and C, they're actually kind of the same shape, just on a smaller scale. And then blade C, number 10 blade, is by far and away the most common. And this is the one that, surgeons are going to use or docs are going to use to make longer incisions. And so this is the kind of one that if you were wanting to open up someone's belly, you just go from, their sternum down to their pubis and just cut all the way down. That's kind of the one you'd use for the longer incision. And so the most important step for reducing the risk of wound infection is to go ahead and clean it out. That is pretty straightforward, but not something to forget. You want to get rid of as much dead tissue and any contaminants that you can. There have been a few surgeries where I've seen, like with car wrecks and things, you'll have bits of the gas pedal in there, or like if someone has wrecked their dirt bike or something, they can have dirt in the wound. And so just really cleaning that out is really important in order for bacteria to, keep bacteria out of the body, at least the kind of bacteria we don't want. And so the best way to do that is to pour off the saline in tap water. There's actually a saying that goes, the solution to pollution is dilution. And that essentially means if there's any pollution in there, any dirt, just dilute that with tons and tons of water just to get it out. And you don't want to use hydrogen peroxide. There have been a few reasons that I've heard that to not use that. I'm not exactly sure the most accurate reason, but I've heard that it can break down suture. more quickly, and it can also introduce air into kind of deep spaces. And then, yeah, you want to cut out dead, fragmented tissue, because if it's dead, then it's not going to heal, and can be kind of a vector for bacteria. And yeah, that's what the very next thing says. So next slide, please. So this is just a kind of an image to bring us into the next slide for the principles and techniques of laceration repair. And so this one is kind of a busy slide, but it's just the different types of sutures that you'll typically have. These simple interrupted closure. If you've heard someone say that they got like 10 stitches, they typically got this kind of closure, because it's just one stitch, tie it off, cut it, one stitch, tie it off, cut it. I've got a little fancy schmancy whiteboard here that I think might be of help. But anyway, so with a simple interrupted, I don't know if you guys can see that, it'll just go, geez, I'm not really good at this. Here we go. Like 1, 2, 3, 4, just kind of down the line like that. It's just one loop after another, tie it off. With a continuous one, the way that one works is you lock the suture at the end and then you just keep running it. And so you'll do one bite and then take it out and do another bite. And so those end up looking like this. I'm going to draw it out here so it doesn't look terrible when I actually do it. So this is what that looks like. And if you can see the little dotted lines, that is where it's actually going beneath the skin. But from the outside, it'll just look like a bunch of horizontal lines. And those are really the two that I want to draw. The rest are just kind of better to talk through. For a locking continuous, it'll look very similar to a continuous, but you're making a loop and then going beneath that loop in order to lock it. Really, the main reason you want to use for one of those is for something that's bleeding really heavily, which is typically you'll see those with a C-section, because uteruses or uteri bleed like crazy, and they really want to cut that bleeding off quickly, so they use a locking continuous. For a subcuticular, like I said earlier, that's just right beneath the skin. That one's good because you can't see it from the outside, and it results in a lot less scarring than a conventional style of suturing. For a vertical mattress and a horizontal mattress, those are once again ones that are a little harder to talk through, but those are both good for for a vertical mattress, it's useful in maximizing wound eversion. And so essentially what that means is bringing the ends of the wound up and together like this, because it's better for them to be like that when healing. Whereas a horizontal mattress is better for fragile skin. It just gives you a better bite and more surface area. It's kind of like with like snowshoes, how they're a bit wider. You can step on snow and not break through. With a horizontal mattress, you've got a little more surface area on the actual skin, and so it shouldn't break as easily. And then for a deep closure, usually you'll just be sewing up fat in cases like that. And the main purpose for that is to just close dead space, and so bacteria don't get in there, and to decrease the superficial wound tension. That's a lot of words, and so I'm sorry if y'all got bored with that, but there are just tons of different styles of suturing. And these are just a few, and there are actually some forms of suturing that people will like make up, and certain surgeons will use a style of suture that no one else uses. But the main purpose for all of these is just to bring the tissue closer together in order for it to heal. Okay, so the average time, this is the average time to take out sutures. So if it's on someone's face, you'll typically take that out in 3 to 5 days. The less time a suture is in, the less likely it is a scar. And people don't like scars on their face typically. It's not the end of the world if someone's face scars, but if you can make someone happy by giving them less of a scar, then you should do that. For the neck, it's 5 to 7 days. For the scalp, I I honestly haven't seen that many sutures be used on scalps. Most people prefer staples just because they're much quicker, but it's still the same. It's 7 to 12 days. For the upper extremity and the trunk, it's 10 to 14 days. For the lower extremity, it's typically 14 to 28 days. If you think about it, there's usually more tension over the lower extremity just because the muscles are a bit bigger and the skin is tighter usually in your lower extremities, and so takes a little while longer. And then for the soles, palms, back, or over joints, that's usually about 10 days. And anytime that you have a suture and you start seeing pus come out of it, like the yellow pus, or it's really hot to touch, or it's swollen, you need to go ahead and take that out because it's likely infected. I think that may have been the last slide. And I think there's a video coming up on the basics of suturing. And then if you guys have any questions at the end, please feel free to ask. I'd love to answer them.
Yep, so normally this is the part where we would hand out the suturing kits and let you all actually try suturing, which is the fun part. But instead, since we are forced to be in a virtual world, we're going to show you a video done by a general surgery resident, and then we'll open it up and let you all ask questions to Jared. If y'all can give me a thumbs up if you can hear this in a minute, I would appreciate it.
Lose my mind. You've been gone for so long. I'm running out of time. I need a doctor. Call me a doctor. I need a doctor to bring me back to life.
Hi, I'm Rachel Morris. I'm the general surgeon resident. I do general surgery. Today
Brian, I can't hear.
Can y'all not hear it?
No.
Hang on.
Sorry, guys. We never know if it's our own internet or.
of the needle driver so that it's.
There you go.
So this would be wrong.
I heard that. If you want to back it up a little bit, Brian.
Usually I like to go call it pickups.
I don't know. I can't hear that either.
Chopsticks. You want to hold them like this.
It's better.
Like this. So the first thing I like
Brian, can you mute yourself maybe?
Put it at a 90-degree angle.
Sorry, guys. Can you hear? You want to give a thumbs up? No, we're still, it went out again, Brian. It's just kind of static.
Thing that we need to do is we take
Let me try to share it again. Sorry, guys.
our nice fake skin here. You can pick whichever one of these designs you want to try and
Perfect.
stitch back together. And the first thing to learn is just how to throw a stitch. I think the best thing that I can teach you is that whenever you pick up skin with your forceps, you kind of use it to bring the skin where you need it to be. And when you throw your stitch, you want to go in at a 90-degree angle. And everything is all about rotating your wrist. So very similar to the way that you open and close a door like a doorknob. That's how you want to turn your wrist in order to take your stitch. So you'll throw the first stitch on one side and come up through the middle. And again, rotate your wrist out and pull the large excess of suture that you have all the way through. Load your needle back, and usually you'll do that with your forceps. These are not the best. They're also called pickups, by the way. And then you're going to take another, what's called a bite on the other side. And you're going to finish by, again, rotating your wrist like you're turning a doorknob and pulling suture all the way through. The next skill that you need to know how to do is actually how to tie a knot. I'm going to teach you how to tie what's called an instrument tie, which means that you use the instrument in order to tie the stitch down. The first thing is I always use what I call the V method. So if you notice that both sides of this stitch make a V, and there's a middle part of the V, and I always put my needle driver in the middle of the V, and I'm always going to throw towards the short end. So this little tail is my short end, and it actually makes it easier if you make it kind of short. So I put my needle driver in the middle of my stitch, and I'm going to wrap this way, goes clockwise towards the tail. And for the first, what's called a throw, I always go around twice. That's called a surgeon's knot when you go around twice. So I'll wrap once around and then twice around. And then I open up my needle driver and I grab the end of the tail. And then I pull this stitch off. And then I make sure it lays down flat. So if you can see how kind of this stitch lays down flat, it's not bunched up. Now my tail is on the other side, and I'm going to do the same thing. This time I'm only going to go one time around, but I put my needle drivers in the middle of my V. Let me make this look more like a V. Right now it kind of looks just like a weird letter. We'll see if we can make this work. So I go in the middle of my V, and I wrap towards the tail. I pick up the tail, and I pull it back through, and I lay it down the other way. So I'm always going to cross sides. So you'll see the tail goes from what's my right side to the left side to the right side to the left side. And that's to make sure that you have a square knot. If you don't have square knots, your stitch won't lay down, it won't stay tied. And that's always bad when you're trying to fix something if the stitch comes untied. So one more time, I put the needle driver in the middle of the V. I wrap towards the tail. I grab the tail, and then I make sure that the tail goes to the other side. So if you want to see this in fast time or faster time, I'll still go a little slow. And I know it's hard to see when I put my hand in front of the camera. And so you end up with some nice knots here. If this looks like a real pretty friendship bracelet, it's actually just a bunch of half throws together. You want it to kind of look a little bit gnarly to know that you threw nice square knots the whole way down, but this won't come out. This will stay together. And then of course, the very last thing to do, since this is what we call interrupted, this is fancy when you can put both sides in your needle driver and you can cut them together. If you have an assistant, they'll cut for you, but if you're by yourself, you have to cut for yourself. You cut the stitch. So that's one stitch. So when people always say, how many stitches did you get? They're usually counting interrupted stitches. So the last thing I'll say is that, these are interrupted stitches. They're just single stitches. You cut them every time you tie a knot. So I've tied a knot right here, and I'll show you how to do a running stitch, sometimes called a baseball stitch. So I'm just cutting my tail, and I'm getting rid of that. But I'm going to go ahead and reload my needle. And notice that it's still attached to this stitch here. And I'm going to continue to do to throw stitches, and I'm kind of exaggerating this here a little bit for the purposes of learning, just so you can kind of see how it looks. But usually these would be a lot closer together. This fake skin is pretty tough. And so what you would do is you would have a incision or a wound or something like that, and you would run all the way down until you decided that you had reached the end. And on the very last throw, and notice here, even though I taught you before to come out in the middle of the wound, that's called taking it in two. This one's just taking it in one, where I'm coming through both sides. So at the very end, rather than pulling it all the way through, you're going to leave a little bit of a loop. And now this loop has sort of become your tail again. And just like you tied the same knot before, you're going to tie an instrument tie using the loop. So it makes it easy just to kind of grab the loop in the middle and pull it through. And make sure that you don't end up with a loop in a loop. So pull it all the way through, just like that. And then just like you did before, you cut your tails. Notice you have 3 little tails now instead, because one of these was a loop. And that is a running stitch.
Y'all got that? Everybody ready to do some suturing? Maybe? No? So who has questions? I'm sure you all have some burning questions to ask Jared. So please ask. You can put them in the chat if you're shy and don't want to speak up, but you're also welcome to unmute yourself.
This is the time to ask, even if it's about applying to medical school or his track, and how he got here in his career. If you have any questions like that, this is the time and the person to ask.
Yes, we got a question. Are there any tricks or helpful things to make it easier to have equal distance between bites, especially in running sutures? I think that that's something that kind of comes along with time. Typically, depending on the kind of suture, it's usually a feel type thing, but there are a few types of sutures where, they'll tell you to make a box. And so, for example, for like closure of fascia, you use the kind of 1-to-1 rule. And so I'm going to draw this out so it makes more sense. I'm not doing a very good job of drawing these things properly, so give me a second. So with the 1-to-1 rule, for example, like if you're doing a suture, and this is kind of the diagonal portion of it. Okay, this is really hard to do this looking at a screen. But if you do it like this, Okay, I'm doing it backwards, so I'm just going to show it and talk about it. That would go cool. But it is like it is 1 centimeter down and 1 centimeter over, and that's just one kind of suture. But typically, it just kind of comes with time, and then also getting used to the way that your wrist works and the kind of the angle that it takes. But really, it just comes down to getting more comfortable with it. And then someone said, compared to how hard the world says med school is and your experience in med school, how difficult is med school? Also, is it more difficult or time consuming? That's a really good question. I would say that med school is difficult, not because of necessarily the complexity of the material, but there's just such a great volume of material. I think that something that kind of brings that to light is the fact that if you get into medical school, roughly 98% of people pass. And so it's usually just a matter of sticking with it. And usually the people that drop out of medical school don't do it because it's too hard, but rather like family things come up or they just decide it's not for them. So I would say that difficulty is definitely not a reason to shy away from medical school. I know a lot of people who felt as if their undergrad was a bit harder, and I'll actually say that I think that the classes to get to medical school, like the chemistries and the biologies, can be a little bit harder, but it's all definitely doable, and it is very time consuming. It is very time consuming. So more difficult or time consuming? I would say time consuming. What bachelor's degree did I get? I got a degree in religious studies from UNC. So there are a lot of people who get more of a science background, and I got more of a humanities one. And the way it kind of works as far as applying to medical school, there are just set classes that you take. They're usually around 10 classes, 2 rounds of biology, 2 rounds of chemistry, 2 rounds of physics, and then a few more things that are just kind of interspersed. And so you can really do like whatever major that you want to do and go to medical school. And I actually think that it kind of helps you to not have a science background if you don't want one, because it makes you look a little different. And someone asked, what was undergrad at UNC like? It was really, really great. I am a big fan of public schools. I think that if you're from North Carolina and you can go to public school, then you should, because the taxpayers are helping you pay tuition. And then also, I just believe that you should stay in state if you want to stay in state. But it was really nice. They've got great sports. They've got great classes. They've got big classes. They've got small classes. It's a really cool place to be with some fun stuff to do outside of Chapel Hill, like in Raleigh and Durham. It's a great place to be, and lots of different people go there, so you can find your group no matter what kind of person you are. What has been your hardest class? I'm not sure if that means for medical school or for undergrad. I would say for undergrad, my hardest class was actually Chemistry 101, like the very first chemistry. I'm not a great chemistry person. And then also it tends to be that some of those first classes are more like the kind of weed out classes, which are a bummer, but there are like 400 people in a class, and they'll try and make it really hard just to see if you can get through it. But that being said, if you take it seriously and do your homework and do the prep that you're supposed to do and reach out for help, then you'll be fine. In your experience working with nurse anesthetist versus anesthesiologist, which profession interacts with patients more? Which does more of the hands-on? I would honestly say that it's pretty similar. I think anesthesiologists take on a little more complex patients, like the people that are more likely to like code on the table, or the people that really may not be the best candidates for surgery but are getting surgery, but it's risky. I think that the anesthesiologists handle those people. And which profession interacts with patients more? I would probably say CRNAs. They probably do more prep of the actual patient and talk to the patient. The anesthesiologist will usually interact more with the CRNAs themselves and kind of be more like a helper when things go bad, but which things usually don't go bad. But that's a great gig if people are thinking about it. Most people that I know that are CRNAs really love their job, and feel like I'm on the right path. But that's true of anesthesiologists too. And as far as the more hands-on, most of what you're going to be doing there is placing IVs and like medication management, and then intubating, and CRNAs definitely do that too. On the suture pad, it kind of pointed, kind of the pointed cut and the 3-pronged cut. How would you suture that? Okay. So it's actually funny that you asked that, because I've got the same exact suture pad as Rachel did there, or Dr. Morris, and I think you're talking about this one, right? That kind of Y. Sweet. And so the way you would do this is you would probably do 3 different sutures. You probably do 3 different runnings, or you could do the interrupteds if you wanted to. But if you want to do a running, you would probably lock here and then just come down to the center. And then you would come up to the top here and lock and come down to the center. And then you would lock here and run it and come down to the center and just tie that off. Or we could just do simples and just go 1, 2, 3, 4, 5, 6, and you just kind of suture it off like that. And Sarah asks, how did you know the medical field was for you? That's another great question. My mom was a nurse. My dad was a barber, or is a nurse. They are still working. And she really loved her job a lot, and talked about how she loved working with patients, and it was always something new. And I think it's a really service-oriented job, and I kind of like that. And it's stable, and you don't really have to worry about being hired, because if you go into the healthcare field, people are always going to be sick. People are always going to need healthcare, and so I think that was a big part of it. And I actually went to UNC and thought I was maybe going to do med school, and then got a little discouraged. I kind of came from a smaller high school, and when I went to UNC, I kind of felt like a small fish in a big pond. And for a while there, I transitioned courses and was going to do nursing, which is a great field, and nurses love their jobs, and they get jobs wherever they want jobs and are paid well. And so nursing's a sweet gig too, and you can be a nurse practitioner out of that, or a CRNA. There's a lot of places you can go with that, or a flight nurse, which I think might be the most bad A job in healthcare, is being a flight nurse. But I had a teacher that said that maybe I might be more suited for medical school, just with the way that I like to kind of delve a little deeper into problems. And so I went the med school route. But overall, what kind of sparked it was my mom really loved her job and really loved taking care of people. And I did a little bit of shadowing and realized that it was a pretty cool job. And so here I am. No regrets. But these are all really great questions, guys.
Yeah, we really appreciate all of you guys asking questions. And if you have any more, feel free to ask more. If not, we'll wind it up. We want to be aware of everyone's time. You got one more question, it looks like.
How did you figure out what your specialty will be? That's a great question. I'm currently working through that one. But luckily with med school, you get to have rotations. And so you will, at baseline, you will get family medicine, pediatrics, OB-GYN, general surgery, internal medicine, and psychiatry. So you will get to see what those are like. And then they also build out time for you to further explore what you might want to go into. And so it's really just a matter of like trial and error. And kind of the big picture, most people decide whether they want to do something more medical or more surgical. And from there, they'll further kind of hone down what they want to do and just try fields out. But for most people, it's just a matter of figuring out, what they like to do. And there are stereotypes that are associated with each kind of field. Like surgeons are known for really liking to work with their hands, whereas lots of people that want to go into family medicine really enjoy like long-term care and get to know the entire family. Whereas psychiatrists like the more like psychological part of it and talking to people and hearing people's stories. And so it really depends on what fascinates you the most, and then also just getting time in those various fields. Luckily, with medical school, one pro to it is that you definitely get to see a lot of different things and get to figure out what works for you.
Okay, well, if nobody has any more questions,
Yeah,
Ron
and
has I'm sorry, go ahead.
I will actually drop my email into this chat, and if anyone has any questions that come up either now or 10 years from now, I'm going to use my Gmail because UNC will not turn that one off 10 years from now. But if anyone ever has any questions about either trying to apply to college or apply to medical school or really anything else, you can reach out.
That's awesome. Thank you so much.
Guys, I put a short poll up. If you could take that real quick, we would greatly appreciate it.
If you could just hang out 1 second after the poll, I'll share your certificate of completion so you can provide that for your teacher if you need to. But the poll should be very short and easy.
Okay, it's closing down. You guys, 10 seconds left.